So thanks, Mr. Chairman. I'm going to try to keep in time. Less than 4 minutes. This is a study done in multi-center study done in Argentina between several groups in HPV centers, analyzing the long-term results of our patients with Caroli's disease. We did the first analysis that published in Journal of Gastrointestinal Surgery, and this is a follow-up adding more patients from different centers. The number of centers were 9 centers from different places of the country. This was study performed between 1991 and 2017. 15 patients with Caroli's disease and Caroli syndrome. Diagnosis was performed by US, CT, ERCP, and MRI. And in all patients, the diagnosis was confirmed by histology. Demographic, clinical, surgical, and pathological variables were analyzed. The results, we know that 58 patients in this series were females. The average age of the patients was 49 years, and the range was 20 until 71. 85.5 patients were symptomatic, and in these patients, the predominant symptoms were cholangitis, abdominal pain, and jaundice. The left hemiliver was involved in 67.3% of this series, and there was a bilateral disease in 22% of the patients. The surgical procedures performed when the disease was located in one hemiliver. The predominant resection was left lateral sectionectomy in 19 patients, hepatectomy, left hepatectomy in 18 patients, and a right hepatectomy in 6 patients. In cases of bilateral disease, there was 1 right hepatectomy, 3 left hepatectomies, 5 hepaticogynostomies with duct clearance, and 3 orthotopic liver transplantation. The morbidity of the series was 32.7%. 57.9% of the patients were followed-up for more than 6 years, and the median follow-up of this series was 129 months, with 83.6% of the patients alive and free of symptoms. The pathological explants macroscopically were compatible with Caroli's disease, and also the histological showed the signs of Caroli's disease. Congenital hepatic fibrosis was determined in 4 patients, 7%, and cholangiocarcinoma was present in 2 patients, 3.6%. As we see in these different series published since 2002, there are 2 series of our group, 1 series from our group and 1 multi-center study from Argentina. The unilobar disease is more common than the bilobar disease. The congenital hepatic fibrosis range from 8 to 29% in one series, and the presence of cholangiocarcinoma is around between 4 and 33%. But if we analyze the recent meta-analysis published in 2018, the Caroli's disease range of malignancy is 5.6%. Hepaticogynostomy is an option for patients that have a bilateral involvement in early steps of the disease. And this is the series that were published referring this treatment for bilateral Caroli's disease without syndrome, without congenital hepatic fibrosis or portal hypertension. So in conclusion, Mr. Chairman, Caroli's disease is more common in females with left hemiliver involvement. Surgical resection is the best curative option in unilateral disease with long-term survival free of symptoms and complications. In cases of bilateral Caroli's disease, hepaticogynostomy could play an alternative treatment in selected cases before indication of liver transplantation, but it's clear that a close follow-up in this patient is recommended. Thank you very much.
Can we have questions from the floor? Yeah.
Yes, Bergenfeldt from Sweden. I would like to ask you, what do you think is the reason of the left predominance? This was a surgical series. Do you think there are right cases that will never reach surgery, and that's the reason for this discrepancy, or?
Yeah, if you analyze the series, is commonly the left predominance, but I don't know. I don't have the explanation why. No. But in our series, there was in our center series, that is involved in these cases, we had the left lobe was almost 75%. We had cases also with when we're in the right, not with all the right involvement of the whole liver, but also sometimes where the anterior sector or the posterior sector, so the resection in the right sometimes was less than that. So I don't have the explanation why the left lobe is usually involved, but it's good for us, for surgeons, it's good in this disease.
Yes, very nice. Do you think, were these adult cases, or were there also pediatric cases in this series?
Yeah, no, these are only adult cases.
Yes.
And one important consideration that I made in my keynote 2 days ago is that we need to be very careful when we mix patients. Pediatric patients sometimes are patients that are treated for a 4A biliary cyst. That extrahepatic component is treated in the pediatric age, and then the component intrahepatic cause problems and is treated in the second step when they are adults. And some of these cases are usually mixed in series of Caroli's disease. So, and this is not Caroli's disease. This is a type 4A biliary cyst intrahepatic component. So this is only a consideration that I should recommend.
I remember your presentation yesterday, I think it was, yes.
Yeah.
Okay, thank you.
Thank you very much.
I have 2 questions to you. This bilateral disease, and you do the hepatogenostomy, what is your protocol follow-up for them? With the imaging or CA99? How often you do it?
No, it's very important question. First thing we do is when we do the cases that we have 12 years and 14 years after the hepatogenostomy, it's important to follow these patients, avoid having residual stones, and we follow by MRI plus CA99. If we analyze retrospectively, in our 4A cyst, that this is not the series, in our 4A cyst, we need to be very careful because not treating the intrahepatic component, have more malignancy. So in 4A cyst, probably we need to treat it earlier than in Caroli's disease if there is persistence of the stones. So your second question?
Yeah. And second is indications for liver transplant in these patients.
Well, the indication I see most clear is when there is association with congenital hepatic fibrosis or portal hypertension. This is the first indication. And the second indication must be related that if the patient has a bilateral disease and cannot be treated by percutaneous or cleaning procedures, considering that if the patient has one episode of cholangitis per year and can be relieved of the symptoms, it seems that the biliary tract is okay. So probably these patients are not going to develop malignancy. But I don't think we need to transplant, that some papers said we need to transplant patients with Caroli's disease as a prophylactic treatment. I think we need to do it when the patients and the clinical state of the patient deserve it.
Okay. Thank you. Thank you very much.